Welcome to the program. I'm Sarah, and today we're unpacking a condition that is perhaps one of the most common, yet most misunderstood disorders in reproductive medicine. We're talking about Polycystic Ovarian Syndrome, or PCOS.
And I'm Mark. Sarah, I think the best place to start is with the name itself. Polycystic Ovarian Syndrome implies that the primary problem is cysts on the ovaries. But as we'll discuss today, that's actually a misnomer. These aren't true cysts. They are arrested follicles.
Exactly. PCOS is an endocrine metabolic syndrome, not just a gynecological one. It affects up to 18% of women of reproductive age worldwide, and it's the leading cause of anovulatory infertility. But beyond the ovaries, it touches insulin signaling, cardiovascular risk, and even mental health.
Our title today is Identifying the Treatment Targets of a Disrupting Ovarian Physiology. We're moving away from a one-size-fits-all approach and looking at the specific pressure points where we can intervene to break the vicious cycle of androgens and insulin.
We're going to cover the HPO axis disruption, the string of pearls morphology, the insulin resistance paradox, and the latest in treat-to-target strategies. If you're a clinician, this is your guide to moving beyond the ultrasound and into the physiology.
Let's get into the biomechanical core of the problem. Sarah, in a healthy cycle, the hypothalamic pituitary ovarian axis is like a finely tuned orchestra. What happens to the conductor in PCOS?
The conductor is the GnRH pulse generator in the hypothalamus. In a healthy female, GnRH pulses vary in frequency throughout the cycle to prioritize either FSH or LH. But in PCOS, the GnRH pulse frequency is persistently high.
And when that pulse is too fast, the pituitary gets a specific signal.
Right. High-frequency GnRH pulses favor the production of luteinizing hormone, or LH, over follicle-stimulating hormone, or FSH. This leads to the classic high LH to FSH ratio we see in these patients.
So we have too much LH and not enough FSH. How does that translate to the ovary?
This is where the theca cells come in. LH stimulates the theca cells to produce androgens, specifically testosterone and androstenedione. Because LH is constantly elevated, the theca cells undergo hyperplasia. They get bigger and more productive. They become androgen factories.
Meanwhile, the granulosa cells, which need FSH to convert those androgens into estrogen, are starved.
Exactly. You have a mountain of raw material, androgens, but no workers, FSH and aromatase, to turn it into the final product, estrogen. This is why we see high levels of testosterone and low levels of estradiol, which prevents the dominant follicle from ever forming.
Now, we can't talk about PCOS without talking about the shadow player, insulin. About 50% to 80% of these women have insulin resistance, regardless of their weight.
This is the insulin paradox. While the muscle and liver cells are resistant to insulin, the ovaries stay sensitive to it. In fact, insulin acts like a co-gonadotropin.
It actually helps the LH?
It does. High levels of insulin, hyperinsulinemia, directly stimulate the theca cells to make even more testosterone. But it gets worse. Insulin also travels to the liver and tells it to stop producing sex hormone binding globulin.
Ah, SHBG is the handcuff to testosterone.
Precisely. If you have less SHBG, you have more free testosterone circulating in the blood. This free testosterone then travels to the skin to cause acne and hirsutism, and it goes back to the brain to keep that GnRH pulse frequency high.
It's a closed-loop system. Insulin causes androgens, androgens cause more abdominal fat causes more insulin resistance. It's a death spiral for the metabolic system. Let's talk about the ultrasound. We've all seen the report. Polycystic Ovarian Morphology, or PCOM. Why is this happening?
Because of the FSH deficiency we mentioned earlier, the follicles begin to grow, but they can't finish the job. They get arrested at the early antral stage, usually about 2 to 9 millimeters in size.
So they just sit there, frozen in time.
Exactly. They aren't cysts filled with bad fluid, they are immature eggs that never reached maturity. On ultrasound, they align along the edge of the ovary because the stroma is so dense. This is the string of pearls appearance.
And these arrested follicles produce anti-Mullerian hormone, right?
Yes, AMH levels in PCOS patients are often 2 to 4 times higher than normal, and while high AMH sounds like lots of eggs, it actually inhibits FSH sensitivity even further. It's another lock on the door preventing ovulation.
So to diagnose this, we use the Rotterdam criteria. You need 2 out of 3. Oligo or anovulation, irregular periods, clinical or biochemical hyperandrogenism, hirsutism or high blood testosterone, and polycystic ovaries on ultrasound.
And interestingly, if a patient has irregular periods and high testosterone, you don't even need the ultrasound to make the diagnosis. The physiology is enough.
Okay, we've identified the disruptions. Now, how do we target them? What are our treatment targets?
We have to prioritize based on the patient's goals. Target 1 is metabolic stabilization. This starts with lifestyle. Losing just 5 to 10% of body weight can reduce insulin levels enough to restore spontaneous ovulation in many women. Target 2 is androgen blockade. If the goal is clear skin and less hair growth, we use combined oral contraceptives, COCs.
Why COCs specifically?
2 reasons. The estrogen component in the pill tells the liver to increase SHBG, which soaks up the extra testosterone, and the progestin component suppresses the LH surge, shutting down the androgen factory in the theca cells.
And we often add spironolactone, right?
Yes, for hirsutism. It's an androgen receptor antagonist. It basically plugs the lock so the testosterone key can't get in. But remember, patients must be on birth control because it can feminize a male fetus.
What about metformin? It's not just for diabetes here.
Metformin is our insulin target. By making the liver and muscles more sensitive to insulin, we lower the co-gonadotropin effect on the ovaries. It's especially effective for women with a high BMI or those who are at risk for type 2 diabetes.
What if the patient wants to get pregnant? We can't use COCs then.
Then, our target is ovulation induction. For a long time, clomiphene was the king, but the new gold standard is letrozole.
Why letrozole?
It's an aromatase inhibitor. It briefly lowers estrogen levels, which tricks the brain into thinking there isn't enough. The brain responds by pumping out more FSH, which is exactly what the PCOS ovary needs to push a follicle past that arrested stage.
As we wrap up, Sarah, what is the one thing you want clinicians to remember?
PCOS is a lifelong condition. Even after a woman is done having children, she is at a significantly higher risk for endometrial cancer due to unopposed estrogen. If she isn't ovulating, she's not producing progesterone to protect the uterine lining.
So even if she doesn't mind the irregular periods, she must have a withdrawal bleed at least every 3 months to shed that lining.
Precisely. PCOS is a disruption of rhythm. Our job as clinicians is to identify which part of that rhythm, the insulin, the androgens, or the ovulation, needs the most help.
This has been an incredible deep dive. Thanks for joining us.
Stay clinical, stay curious. We'll see you next time.